Well, good evening, everyone. I'm Marco Rizzo and co-chair with Dr. Chuck Cassidy for our Advanced Risk Summit. And on behalf of Chuck and myself, we are delighted to share this extra session of the Advanced Risk Summit. And we called it Take Home Pearls, and a review of these last 3 months, which have been extraordinarily educational. And we owe such a debt of gratitude to our faculty, who have been nothing short of superb and worked tirelessly to help make this educational event so enriching. And I want to thank each and every one of them from the bottom of my heart. And their enthusiasm for teaching is so extraordinarily inspiring, because this session was an add-on, largely in part driven from the faculty, and we thank you. Another upcoming AO hand education committee for North America session. That's going to be another seminar series of weekly sessions from April 29th to June 10th, focused on hand therapy essentials, where we examine the relationship between hand surgeons and therapists with online case discussions with experts. This is chaired by Chai Mudgal and Becky Nadisky. And we can't thank them enough for arranging this great course, and we look forward to seeing it unfold. You can assess these recordings on YouTube at AO North America Hand, and the link will be recorded in about 24 hours after this conclusion of this webinar. So I'm going to get things started, and what we opted to do for this format was to have about 10-minute sessions focused on 10-minute summaries focused on each session. And I'm going to start us off with the DRUJ. Unfortunately, Dr. Doug Hannell was unable to really be with us tonight, so I'm going to speak to this as I was part of the faculty for this session. So I want to overview our session, and basically included an overview of the anatomy and biomechanics from Dr. Fisher. Fracture fixation was reviewed by Dr. Dennison, and what to do when the DRUJ is still unstable or problematic and associated with radius fractures. I spoke a little bit briefly on post-traumatic ulnar impaction, whether to shorten the ulna versus lengthen the radius, and what is the role of resection arthroplasty. Dr. Kennedy spoke at length about that. And Doug gave a wonderful talk on what to do when things don't work. And I'll present a case real quickly illustrating a similar type scenario and how it played out. Dr. Fisher's review was superb. He was able to talk about the 3 components of the DRUJ: bony constraints, soft tissue constraints, the extra-articular contributions to stability. We have to remember that this is part of a larger construct, and the bone joint forearm complex, including the elbow, the wrist, and the forearm. And the problems that we typically see associated with the DRUJ is instability. It has a fairly shallow articulation, depending a lot on the soft tissue constraints, impaction or malalignment, or other sequelae of malalignment, and of course, pain related to arthritis. Dr. Axelrod appropriately called this sort of the black hole of the wrist, but it's more like the low back pain of the wrist, as we've learned to respect and appreciate the problems that can occur from the ulnar side of the wrist. Dave gave a wonderful talk, Dr. Dennison, on fracture fixation and how to manage the associated ulna and its problems when combined with a distal radius fracture. We recognizing the problem was critical. Identifying whether bony fixation and restoration, if possible, that would be plan A. Soft tissue stabilization, of course, needs to be considered when necessary. Sometimes pinning as an adjunct is necessary. And prevention, highlighting the key prevention of instability, recognizing, having a heightened awareness for instability. All of these will help down the line, because chronic instability is obviously more troublesome to manage. I created a little bit of a question answer about thoughts related to distal radius malunion and when to consider shortening the ulna versus lengthening the radius. And we spoke about questions you want to ask yourself: how much malalignment is there? The age of the patient, activity level of the patient, the amount of ulnar variance that's off, whether or not there's an associated instability after you've corrected, and how to manage it, and created this idea of how to approach it, or how I view approaching these, and when to proceed with different treatments. And Dr. Kennedy gave a wonderful talk on the ulnar resection. It's arguably still the most common method of managing DRUJ arthritis amongst hand surgeons, largely from the simplicity of the procedure. But we also have learned to respect that about 8 to 10% of these patients don't do well, and remembering that salvage can be quite tricky and difficult in these patients. In the next few minutes, I'd like to just share a case that highlights some of these, and if time allows, I'll solicit some opinions from faculty. And this illustrates the humbling nature of the problems at the ulnar side of the wrist. This is a 38-year-old truck driver who fell on the job and sustained this fracture. And at this point, I opted to treat him non-operatively, and radiographically, he went on to heal fairly adequately. He 6 months later had ulnar-sided wrist pain, which was troubling him quite a bit. I worked him up, and we performed an MRI, which showed evidence of a TFC tear. He did have foveal pain consistent with the TFC. His DRUJ felt stable. He didn't have obvious ECU subluxation. And the lunotriquetral interval was relatively painless, as was the pisotriquetral joints. I moved forward with an arthroscopic debridement of the TFC. He did have a central tear, and he went on to do okay for a little while, but 1 year post-injury, he did have persistent pain at the ulnar side of the wrist and described pain along the ECU tendon. He had some subtle instability that was more appreciable. His previous MRI didn't show ECU tendonitis, but I did offer to inject it, and he tolerated the injection well and had favorable temporary results. About a year and a half injury, he had persistent pain, and his symptoms were quite severe. He said he couldn't cut steak and he couldn't feed himself so well. So I opted to move forward with exploration and ECU stabilization and tenosynovectomy. We went ahead and did this, and it wasn't really super inflamed. And I unfortunately didn't really help him in the long term. Here he is now 2 years after injury, and I'm still struggling to try to figure this guy out in terms of how to help him get better. He had painted to DRUJ. So now I'm starting to think he has arthritis. I see bone spurs here, which are concerning. And I thought to myself, and this is the only question I'm going to ask, is what would you do at this time? Dr. Stern, I see your video there. What would you do with this guy at this time?
I'd probably give him more time, do a diagnostic injection into the distal radioulnar joint. This looks pretty bland to me.
Yes, I injected him and he got better. Now I will say, and I'm not blaming, he is a work comp, so I took that into account when I'm dealing with this 2-year history of what to do, and I tried my best to avoid any further surgeries. I did do a monumental event that I want to caution people. I did do a distal ulnar resection at that point. We talked about an ulnar head replace. I was going to explore it, and I did find some evidence of arthritis, or at least I convinced myself of it. And we went in with a plan A, B, and C. He was really reluctant to undergo an ulnar head replacement at that time, so we ended up doing a DERA. And it did help for a short while, but unfortunately, by 6 months later, he was still having pain. He had convergence, and ultimately, I went ahead and did a allograft interposition stabilization. And I'm going to move through quickly. He was one of those rare patients who had like a reaction to the allograft. I ended up taking it out, and ultimately, he left him with a DERA. Unfortunately, he went on to have tendon ruptures, and then I fixed those, and I did a BR wrap a la Dr. Gupta. I did an interposition with the wrap, which I would love your thoughts on at some point. it was quite satisfying in terms of stabilizing him. But unfortunately, it never really helped his pain. And ultimately, we talked to at this point about doing a Schecker implant versus a one bone forearm, and he ended up with a one bone forearm. That was his preference. It did solve his pain, but sadly, it was a long story, and it brings home the point to respect the DRUJ. You know, that ulnar head is critical, and whenever you commit to resecting that ulnar head, be prepared for the small percentage of patients that have trouble. And I'm going to move on to the next talk. So I'd like to have Dr. Axelrod set up, and if anyone has any comments about that case, it's a bit laborious, and I feel like I just went to confession, but I feel better about it. So.
The only comment I have, Marco, is that you have my ultimate sympathy. Those are really tough cases. And once you go down a certain road, you're committed, and it's really hard to go backwards, and they're really tough. So that's where I really respect Dr. Stern's advice when he said, I don't see anything too impressive there, so I would just do an injection. So in retrospect, that's the right thing to do.
There's a lot of years of experience telling us I wouldn't go down that road.
Exactly, exactly. Okay, so I'm going to first off thank Marco and Chuck Cassidy for organizing a monumental event over the last few months. This has been a great series for multiple wrist problems, everything from fractures, which I'm going to speak on, to arthroplasty, arthroscopy, and so on. So it's really been enjoyable for us as faculty. It's not quite as good as being there live, but you know, in these times, we do what we can do. So you guys, thanks a million for doing all this.
Thank you, Terry.
I'm going to lead off, Marco, if you want to pull up my slides. Yeah, if you don't mind.
I'm happy to advance your slides.
Great, thank you.
Let me pull up the, bear with me here just 1 minute. I apologize.
It's all good.
Marco, that was a great example of a one bone forearm. I love that technique.
Okay.
Yeah. Okay, so the session that we led off with at the very beginning of the Advanced Wrist Summit was on distal radius fractures. And I had great faculty, and we chose to speak on 4 main concepts. I'm going to use this one case to illustrate some of those concepts, and then just to summarize. So this is a 42-year-old investment banker who's right-handed, a bit of a high stakes player type of a guy, has a snowboarding injury when boarding in the mountains, and has this injury. I think most of us can recognize the high energy nature of this fracture. It's multifragmentary. There's an interarticular extension of the fracture. The fracture follows a very classical kind of columnar approach, which is the radial styloid, radial facet fragment, the central facet, and then the ulnar column, which have all been disrupted. Marco, could you advance, please? And then this is the up close image of that injury. So I'm going to ask Dr. Fisher, if you're on the line, what do you think about this fracture, Tom?
Well, it's a bad fracture.
Thank you.
That's all there is to it.
Yeah.
No, I think it needs, this is the ideal fracture for getting a powerful translation towards the ulna. And for me, that's that radial column plate. And, you know, once the radius is fixed, then you got to decide, do I need to do something that ulna? Do I need just to put a pin in it? Or I need to fix it with a plate? But I've gone less and less towards fixing them, as they have tendency to be stable with the radius and anatomically prepared.
Yeah, that's been my experience as well, Tom. It's quite surprising how well it reduces and how stable it is. Even when you're doing a dynamic imaging under the fluoro, you fix the radius, and then you put the forearm through rotation, and it tends not to move. It actually sits where it's supposed to sit. So I along with you, really don't fix them too often unless it remains very unstable afterwards. and my fixation has become more and more limited. So often it'll be no more than a K-wire or two, or perhaps even a K-wire and a tension band wire to stabilize it. Sometimes you do have to use a little plate. I find the plates difficult to apply and not all that satisfying. And sometimes I wonder if I should have just stayed with a K-wire. Jesse, do you have any pearls if you're on the line?
Yes, I would always get a CT scan of this type of fracture.
Okay. I don't have one available, unfortunately. Sorry. Anything you do differently than what Tom has mentioned?
Yes, I think in this high stakes 47-year-old, I would fix the ulna. And
Yeah, tell me if you don't mind how you do that. What's your favorite technique for this particular fracture pattern?
little ulnar plate that hooks around the ulnar styloid, because you have a lot of instability there. And I would do a volar approach to the radius, as you mentioned. And you may or may not need a radial styloid plate, but it doesn't hurt to use that as well.
Yeah. Okay. In my hands, I love the idea of a radial styloid plate for this particular fracture because, as Tom Fisher said, you kind of want a thumb or something to push that radial column up and over towards the ulna. And so if you have a volar plate that can provide that, fine. But I must admit, I really do like using the radial styloid plate in this kind of a circumstance. So I would go with Tom on that one. So Marco,
And
could
Terry,
you
Terry,
Yep.
I think the other trick is a lamina spreader between the radius and the ulna that helps to translate that over too, as the ulna and the radius are still united generally.
That's a good point, Tom. Thanks. So we'll advance to the next one. And so this is what we did. And this was a little while ago. So Marco, can you go ahead? Thank you. So this was second generation of the locking plates, the volar locking plates. So I did use the radial styloid plate, but those of you that know this plate well know that I didn't exactly put it in the right place. So because of the metaphyseal comminution there, I had to put it on more proximal than one would usually do. The plate only really comes in 2 lengths, and this was the longer version. But it did its job, and with those screws going up across into the lunate column, the ulnar column, it did provide pretty reasonable support. It was very stable under the examination under anesthesia, and I elected not to fix the ulna, and it went on to heal quite nicely, and he was very happy, regained essentially full movement. We did not take the implants out, although I do acknowledge when you're using the radial styloid plate, the need to take the implants out is somewhat greater than if you're just using a volar locking plate. So why don't we just move on, Marco? So over the session that I was in charge of, we covered these 4 objectives. The first of which was to consider the rationale for surgical versus non-surgical management of the distal radius fractures in the low demand sedentary population. And the take-home messages from that part of the presentation was not to treat age as an absolute, but rather functional activity and patient expectations. There are many people that are old beyond their years and many people that are young less than their years. And so the demands that you can anticipate and the fracture patterns come into the decision making, not so much the concept of a sedentary population. With our newer devices, we're able to manage more of these fractures with poor bone quality quite easily. However, one does have to temper that enthusiasm with the concept of the literature, which would support the fact that many low demand patients that don't have very high expectations can be managed very nicely without surgery. The second item we covered was that pesky little volar lunate facet fragment that Dr. Jupiter taught me many years ago can be really difficult to manage with the lunate going where that lunate facet fragment goes. It needs to be reduced perfectly and stabilized. And we went over some of the various techniques for doing that with plates that are specifically made for that, tension band wires, little hook plates, that type of thing. The third talk, which was by Anne Willett, was on the limitations of volar plating of distal radius fractures, knowing that not all fractures of the radius can be fixed from the palmar side. There are some with dorsal impaction, with dorsal subluxation of the carpus that need to be approached from the dorsal side or from both sides sometimes. And then the final talk, which was the talk that I gave, which was what to do when the fracture fragments are just too small for fixation and we need some kind of a bailout. And in that situation, I went through the indications for use of a bridge plate, an internal external fixator, that is the Hano plate, which will distract the wrist, keep the carpus well aligned, plus or minus a few additional tips and tricks were covered in terms of reducing the small articular fragments when doing so. So that was my summary of our session, Marco. Thank you very much.
Terry, thanks so much. Wonderful. There's some questions, and I appreciate faculty answering some of the questions. Dr. Gupta and Dr. Malone were answering some questions. I'm going to let Dr. Jupiter go next and speak on the distal radius malunion. Again, thanks, Terry. Much appreciated.
You're welcome.
Terry, I just have one comment. For those of you who take the hand self-assessment exam, there is a question that I wrote on distal both bones, the distal radius fracture with the very distal ulnar fracture in the elderly with good results with non-operative treatment of the ulna. Anatomic reduction of the radius, non-operative treatment of the ulna.
Great, that's good. We did the right thing.
So we're addressing now when things don't go right with your distal radius fracture, and looking at it when you have a deformity of distal radial ulnar joint, distal radial carpal joint, and combinations. We had an excellent faculty who went through these various topics. This was case-based. We illustrated with a good number of cases and tried to cover many of the contemporary issues that exist in decision-making, in evaluation, preoperative planning, the techniques, dorsal volar approaches, the use of bone graft, what type of bone graft, bone substitute, and postoperative management, and particularly expected outcomes, and when things don't go well or it's a non-salvable situation. Most cases came out of this AO trauma, a manual of wrist surgery. As an illustrated example, we use this volar malunion. Notice the prominence of the distal radial ulnar joints, and it covered looking at both the distal radial ulnar joint and the radiocarpal joint. And this was the X-ray as shown, and notice the length discrepancy as well. So Dr. Cassidy gave us an overview looking at indications and timing. For example, if you have a well-defined malunion, can you consider an osteotomy early? How do you do a preoperative planning? When you're looking at something in 2 dimensions, it's sometimes hard to appreciate the rotational deformity. The tracing technique of Fernandez, as illustrated here from his original article in 1982, is still a very viable way to do this. But we looked at the use of 3D CT and virtual planning using computerized modeling. It's expensive, time-consuming, and for extra-articular malunions may not be necessary. The option of bone modeling will probably be a better option in the future. We can do this off of our own computer with CAD/CAM, the making of the models. How to do this, what to do, how to plan it was further discussed by Dr. Hoyne. And looking at that case, this is a volar approach as seen here. And he discussed the pitfalls of if you need length to release the brachioradialis, and looking at the planning using K-wires, both perpendicular to the malunion proximally and obliquely in the plane of the deformity in the metaphyseal segment. Looking at it in C-arm, the goal is to do the osteotomy at the site of deformity as illustrated here. And then, as mentioned by Dr. Axelrod, the use of a lamina spreader, or Fisher was mentioning it, is very helpful in gaining your length and also in avoiding the radial translation of the distal fragment by using the lamina spreader between the radius and ulna. Notice the relationship of the ulna now. Dr. Hoyne also brought out the fact you can use, by planning the deformity in advance, to place the plate in the deformed position and use it to realign the malunion. The question of bone graft is important, as prior to locking plates, we use corticocancellous bone because of the need for better support. But with locking plates, we have gone to cancellous bone or bone substitute for the most part, and the data would support this as well. The advantage of a plate on the volar side was brought out, that it can control rotation just by virtue of the anatomic design. And here was that index case placed in a splint for 2 weeks and then allowed progressive motion as such. I discussed intra-articular malunions and looked at this unusual indication, and looking at primarily when it's well-defined and a major subluxation of the joint, and look at the outcomes in the published literature as well. And lastly, Dr. Stern looked at salvage and looked at the options when doing radiocarpal arthrosis, radioulnar arthrosis, or, as like in this case, combined radioulnar and radiocarpal arthrosis with localized arthrodesis. So we tried to cover all of the contemporary issues and went back to the index case we started with and showed, based upon what we did in the course, the approaches and then the outcome. Thank you.
Thank you, Jesse. Any comments or questions from anyone? We're actually ahead of schedule, so we're doing okay. Wonderful, Jess. Nice review. Thank you. Next up, I'm going to ask Dr. Ree to share his session. Thanks, Peter.
Thanks, Marco. Let's pull it up here. All right, hopefully that should be full screen for everyone. Can you hear me okay, Marco? Thumbs up, perfect. Well, we had a Thursday a session that covered a pretty vast topic, which was perilunate injuries and traumatic carpal ligamentous injuries. And also we talked about SL, including that topic. We had a wonderful faculty that went through and discussed in a seemingly very long case presentation, because we also used some really nice audience participation polls that really helped to see what the pulse of the surgeons out there is for this topic. So Dr. Grossman first talked about the carpal anatomy and the kinematics and the mechanisms of these perilunate type of injuries. And I'll just remind you that the salient points was that the carpus is not just the bone, but it's the ligaments. And that's where we have these carpal instability patterns from these ligamentous injuries. And on the dorsal side, it's primarily the dorsal radial triquetral or the dorsal radiocarpal, with the dorsal intercarpal are the main dorsal ligaments within the carpus, both intrinsic and extrinsic. On the volar side, though, we have the short radiolunate, long radiolunate, and RSC on the radial side, and the ulnocapitate complex. And it's in this weak area here in the space of Poirier that the perilunate mechanism really tries to exploit to create this injury. Now that short radiolunate ligament is very stout in this cadaver section. You can see it really tethers that lunate. And that really is the basis of our understanding of the perilunate type of injury that was really elegantly described on cadaveric studies by Dr. Mayfield. And to simplify it the best that I can, with this axial loading extension carpal supination type of mechanism, the entire wrist goes dorsally or extends. And at some point, that short radiolunate tells the lunate, you just can't extend anymore. But the rest of the carpus says, we're going to go. And the rest of the ligaments will fail in this somewhat predictable pattern that wraps around the SL, dissociates the midcarpal joint, and then wraps to the LT, and then results in the final stage, which is the lunate dislocation. So then we went through this exact case, and Dr. Cassidy shared with us his tips and tricks for reducing and essentially reconstructing these perilunate injuries. And following that, we had Dr. Kevin Malone talk about in cases where that would fail, a primary repair, how would you reconstruct? Now, as you can imagine, an SL reconstruction talk is a vast topic that we just barely scratched the surface. And so I thought a good take-home summary would be just to reiterate how to reconstruct these carpal traumatic instability patterns, because that's really the basis of all these different things that we do to reconstruct these ligaments. And so I think a very mechanistic stepwise approach is as follows, and I'll go through this very, very quickly. I still like to use the dorsal carpal approach with the ligament sparing capsulotomy, and I'll explain why here in a second. But it's described by one of our partners, Dr. Berger. And every time I go from a dorsal approach in these traumatic injuries, I always just take out the PIN. I think that it helps with pain control. And I think everyone in the poll agreed that that was something that they would do. And then we would examine the SL and just decide where it is avulsed off. Is there a bony fragment? How are you going to repair it? And here with the fingers going up to the top, you can see that scaphoid, the proximal pole dislocated and now being reduced on the right here. And then once you identify how you're going to fix it, I do think it's important to decorticate or remove all that avulsed fibrous scar tissue so you can actually give your intact or your remaining SL or LT a chance to heal down onto a good bed. And so I think decorticating and preparing that bed for your eventual SL and LT repair is quite important. And then how you reconstruct this is really just a cookie cutter approach, I would say. First, get the lunate reduced both in the sagittal and the coronal plane. You can do this, you can get the lunate out of extension. A lot of times it's pretty unstable, but you can get it into the right spot by flexing, extending, ulnar radial deviating the wrist, and then putting a radial lunate transfixation pin to hold it. And once you have that stable platform, then you can build everything else off of it, which the next step would be to reduce the scaphoid to that. I just wanted to point out, we stress the lateral, but always make sure that you don't lock this up in an extremely translated or translocated position, either ulnarly or radially. And then reducing the scaphoid is really aided by using a joystick, a fairly stout joystick, like a 6'2" wire. And that's taking the scaphoid out of flexion and also out of the rotation to get that back reconstructed anatomically. And then once you have the scaphoid reduced to the lunate, then you can transfix it with an SL pin. And I think it's quite helpful. One of the faculty had mentioned, and I agree completely, it's much easier to provisionally place this pin when it's reduced or dislocated, because you can exactly see where that pin is going to come out right at the SL interface. So you can get it ready, and then once you got it reduced, just fire that pin across. And then once you have that reduced, we talked about the utility of doing an SC transfixation pin just to offload the scaphoid flexion moment even after your repair or your reconstruction with an SL. But when you do this, be mindful that you don't want to transfix the capitate or the midcarpal joint with the capitate dorsally translated. So making sure that you, instead of this on top here, pushing that capitate head down and getting that capital lunate angle collinear. And at this point, then you can do the same concept of putting your pin to the triquetrum, getting it reduced, firing that pin across. And now you haven't done any ligament repairs, but you've gotten the carpus anatomically reduced, and now you can take a breath and repair all these ligaments. It's important at this point, though, to make sure that you reconstitute Galula's lines, both radiographically, as you can see here, but also intraoperatively. Just do a little bit of traction. You can make sure you don't have any volar gapping, any step off. Make sure it's just right before you actually do your repair. it's pretty rare that you can do there's pretty rare that you have a mid-substance ligament injury, but in those rare cases, you can just repair the ligament. But most cases, what we're doing is a suture anchor repair in today's day of suture anchors. And I will just say that when you do this, leave your tails long, because it may save you here in the end. I guess it's here now. If you have poor substance, let's say a lot of that SL is just really ratty, it's hard to get back together, and you put your suture anchors in, you can use part of that DIC, which is why I like to do the ligament sparing capsulotomy, to just add a little bit of soft tissue augment. Then you can use those suture anchors to pull those down. Or similarly, you can use those suture anchor tails to then pull through the capsule and do a capsular repair too, and reconstruct that dorsal capsular scaphoidinate septum. And we talked about the controversy in doing a carpal tunnel release, or even just going volar. And I think the faculty was pretty mixed on when you would do a carpal tunnel release. But certainly if a patient has profound median nerve dysfunction after this injury, I think we all agree that it's the right thing to release that. But be aware, you do not have to do an extended carpal tunnel release to repair the volar LT, which is another source of controversy. I typically do repair that, as you can see in this picture here. I think it's quite helpful, and as you know, the volar LT is the strongest of the LT complex, and so I like to repair that. And Dr. Hanel very saliently mentioned that it is also important to repair that space of Poirier rent. The rehab, I think everyone most agreed that locking them down for about 8 weeks at the least, and then at about 3 months, letting them get back to gradual activities was kind of the mainstay of rehab. So the take-home points for perilutine injuries or just any of these traumatic carpal instability patterns that you're trying to repair or reconstruct: first, anatomically reduce the carpus, prepare your repair or reconstruction sites, and just get all your anatomy reconstructed, pin it. Again, take a breath, repair all these ligaments. Carpal tunnel release, use your best judgment based on whatever you feel is best for your patient. And then if you do have poor substance of your SL or your LT, there are things around that you can use to augment your repair. Thanks, Marco.
Thank you, Peter. Wonderful, bud. Wonderful. Next, any questions for Peter? We have a minute or two.
Marco, can I make a remark?
Yes, Chai, please.
Hey, Peter, where you showed those K wires going into the scaphoid and the lunate, if you were to put that wire in the scaphoid a little more distal, and then when you, so that it inclines distally, when you pull on it, it inclines proximally, and now your scaphoid comes back to its location from its flexed position. And then you grab both that wire and the lunate wire together with a stout needle driver and just rotate them around each other. So it acts like a self-retaining reduction tool.
Absolutely, and that's a good technique even for SL reconstruction. I absolutely agree that that is a good hand saver when you don't have enough hands to facilitate your reconstruction. Thanks for that that tip, Chai.
Awesome. Next up, Dr. Gupta, Amit is going to speak on scaphoid fractures and give us the summary from that session. And Amit, I think you have, you're already up and running.
Can you see my screen?
I can, yes.
Okay.
Thank you.
So we're going to, our session was scaphoid fractures, and I'm going to give a summary of what we discussed. The faculty, we had a wonderful faculty, included John Capo, John Elfer, and Nicholas Poulos. And this was why we treat scaphoid fractures, because we want to prevent the progression to scaphoid non-union advanced collapse, which has been shown to be present in over 90% cases if the scaphoid remains ununited for 10 years. So the agenda was that we'll present a case and then diagnose a suspected. John Elfer would talk about how to diagnose a suspected scaphoid fracture. Then I talked about what characteristics of the scaphoid fracture point to a bad outcome. And Nicholas would talk about the current algorithm for treating acute scaphoid fractures. And John Capo then described all the surgical tools, the dorsal volar, open methods for treating acute scaphoid fractures. Then we had some case discussions amongst the faculty. So take-home message from John Elfer was that we had suspected scaphoid fracture with snub bulk tenderness, even if radiographs are negative, even after 2 weeks. You probably cannot go wrong with a non-contrast MRI. Even if it's early, you may discover other injuries. While many fractures are unlike ultimately fixed, the important win for the patient is actually discovering the fracture, because an immobilized scaphoid fracture is likely to heal. So then we discussed, with the help of Nicholas Poulos, the SWIFT study, which was published in the Lancet, which is a large study. It was a pragmatic parallel group, multi-center, open-label, randomized superiority trials of 439 patients, which was done in England. They assessed the PRWE at 52 weeks. Of these patients, half of them were treated by cast, the other half by surgery. They found that surgery had more complications, and there was no difference in the union rate. And reoperation complication was more in surgery group. Then they did a 52-week CT for surgical cases and found some screw penetrations in many instances. And again, they found no difference in return to work in surgery versus cast group. So there was no significant difference between cast and surgery in the non-displaced. Remember, non-displaced scaphoid fracture. They took out the displaced ones and treated them surgically right off the bat. And subsequently, if they found that these were displaced in this subsequent X-rays, they did surgery for them. So their conclusion, one of the conclusions was 73 scaphoids need to be surgically treated to avoid one non-union, and the 95% confidence interval was 24 to 100. So adult patients with scaphoid waist fractures displaced by 2 millimeters or less should be treated by initial cast immobilization, and any suspected non-union should be confirmed and immediately fixed with surgery. This treatment strategy will help to avoid the risks of surgery and mostly limit the use of surgery to fixing fractures that fail to unite. We then looked at an exercise of what are the preventable causes of scaphoid non-union. And from the literature, we found that failure to recognize the fracture, inadequate initial treatment, and improper assessment of bone healing, and thereby discontinuing immobilization when the fracture is not healed, were some of the causes. Then we looked at the poor prognostic indicators. In any particular given fracture, what are the indicators? Can we pick out the bad actors? And we identified 4 such things. One is displaced and comminuted fractures. And this has been known for a long time, from 1981. Unstable fractures, fracture patterns which have instability, and the fracture tends to displace, a volar oblique type fracture. Fractures with carpal instability and deformity, and proximal pole fractures. So these we identified as bad actors, and therefore it follows that these are the indications for primary ORIF: displaced and comminuted fractures, unstable fractures, fractures with carpal instability and deformity, and proximal pole fractures. Discussing displaced fractures, there have been a lot of studies over the years, and people have shown very clearly that displaced and comminuted fractures have a very high incidence of non-unions, 19 to 22%. Comminuted fractures are high velocity injuries, really, and once you have comminution, it is by definition displaced, an unstable fracture. And instability is the key point in any scaphoid fracture in terms of union. So if you have a humpback deformity, which is again a humpback, which is a displaced fracture, this is from Graywald's study, it's 7 times chance of non-union. Translation gave you 3.4 times chance of non-union. Comminution give you 2.5 times chances of non-union in terms of odds ratio. Unstable fractures, which have volar pattern, which volar oblique fractures have been shown to be prone to delayed or non-unions. And when you have collapse like this, which is a humpback collapse, they have to be treated surgically, especially from the volar side. So here's a volar oblique type fracture, which was, and then here's the displaced humpback fractures. Fractures with carpal instability and deformity was outlined by Jeffrey Fisk and subsequently by Cooney, Lynchide, etc. And these have again have intrinsic causes of scaphoid non-union. Then proximal pole fractures. It's been shown clearly in the literature that proximal pole fractures have high rates of non-union if not managed by fixation early. And here's a case of a 19-year-old soccer player who was hit on the wrist by a soccer ball. His wrist became hyperextended. He came to the office complaining of pain and swelling in the snub box. There was tenderness in the snub box and scaphoid tubercle, and this was the X-ray. So which appears to be a fairly non-displaced fracture of the proximal pole of the scaphoid. However, when you take him to the OR, you put a pin in it and you see that this is very unstable and you can really separate the fragments. So this would have possibly gone into non-union had it not been fixed early. So here, this again shows the dorsal exposures, minimal exposure on the dorsal side, putting a 14 gauge angiocath in it, and then a guide wire, which is then driven into the distal portion. And this is center-to-center guide wire placement and putting a compression screw across the fracture side just outlines the method of treatment for this fracture, showing the center placement in AP and lateral films. So the poor prognostic, revising again, poor prognostic indicators are displaced fractures and comminuted fractures, unstable fractures, fractures with carpal instability and deformity, and proximal pole fractures, and therefore the indications for primary ORI for displaced comminuted fractures, unstable fractures, fractures with carpal instability and deformity, and proximal pole fractures. So all the rest undisplaced fractures can be treated in a cast, followed by CT scan at 6 weeks. And that is our conclusion. Thank you.
Well, thank you, Amit. Perfect, bud. We are going to take a little intermission. Any questions for Dr. Gupta before we let Chai have the floor for just a couple minutes? Perfect. Thanks, Amit.
I have a quick question. This is Hill Hastings.
Yeah.
What is the thought of your faculty in how to distinguish non-displaced fractures from unstable fractures? Oftentimes an X-ray will show them to be non-displaced, but in fact they are unstable, and they're the ones that at 6 weeks you'll find that you need to later do something about.
Yeah, instability, you can take X-rays in different projections. You can take a radially deviated, non-linearly deviated, and look at the instability from that point of view. Or the best way to define instability is if you do a mid-carpal scope for waist fractures, and then you can look at the fragments or put joysticks in the fragments and figure out the instability of those fragments of the fracture.
Great, thanks. Chai?
Thank you, Marco. Thank you, Chuck. I'm going to make just a couple remarks here since I've been chairman of the AO North America Hand Education Committee just about 2 years now. And I had never in my wildest dreams thought about what the last year would have been. But we have all pulled together and we have made it work really well. We did our first webinars after the start of the pandemic on April 23rd. And since then, we've had 15 sessions for the Must Know series, 10 for the Hand Surgery Essentials, 8 for the Sage on Stage. And we rounded it off with Marco and Chuck doing a spectacular job with 10 sessions for the Advanced Risk Summit. A total of 43 sessions attended by people not only from North America, from all over the world. And to me, that just emphasizes that the Hand Education Committee from AO North America is really one of the premier leaders in hand surgery education for most parts of the world. I cannot thank all the members of the Hand Education Committee enough for doing such a spectacular job, pulling together and making it work for 43 sessions in 1 year. AO North America staff under the astute leadership of Steve Schwartz and Chitra Subramaniam. And of course, the AV staff, as well as Doreen and Joanne, have done such a wonderful job shepherding us like stray cats all through these sessions. Of course, we would never be as successful as we have been without the attendees, because these attendees have been an educator's dream, and they've been interactive, they've been lively, they've shown up week after week. So in all, I think we've made most of the pandemic. And for that, I thank each and every one of you. I have one more year to go, and I'm excited to see what else it brings. But we'll kick off that year by starting off with the Hand Therapy Essentials session, which is about 9 weeks, will be co-chaired by Becky Nidusky and myself. And that starts at the end of April. So watch your mailboxes for the flyers and announcements for each session. So once again, Marco and Chuck, spectacular job. Thank you, thank you, thank you.
Thank you, Jai, and thank you for your leadership and your guidance. And thanks. And I'll reiterate our gratitude to the AO's North America staff for helping make this, helping make our jobs easier. And again, to all the attendees as well. So I'm going to run the slide deck for Hill, but I'll let Hill have the floor here as we talk about the session on scaphoid non-unions. Can everyone see that okay?
Indeed.
Okay.
Thank you, Marco. So my faculty that joined me were Dr. Jesse Jupiter, who talked about non-vascularized bone grafts, Phil Blazar, who talked about staging, classification, and evaluation of deformity, and Dr. Kyle Bickel, who talked about vascularized bone grafts. So to highlight this, starting with Phil, I've asked each of them to present a snapshot from their sessions to give them a chance to present just one aspect from each of their sessions. So Phil, next slide, and next slide.
Thanks,
Phil, are you
Phil, and thanks
live?
to all the faculty in providing me, allowing me to participate. So just to highlight this, we're going to talk about a 22-year-old female right-hand dominant who presented with wrist pain after an injury prior. So many of our scaphoid non-union patients do. She had x-rays initially, which were not showing a fracture, but her wrist never got better and it was worse with loading. Next. And here are the x-rays when she presented to me at a year, clearly with a fairly proximal injury without evidence of union. Next. And this was evaluated as most scaphoid non-unions, I think in my practice currently, are with a CT, which demonstrates that she actually has a very small, very proximal non-union with certainly evidence of cystic formation and resorption. But fortunately, there was not much evidence of instability in that there was not a lot of collapse, no humpback, and no degenerative changes. Next. So given those positive factors, we elected to treat this non-union from a dorsal approach. I think you can see in the image to the left that we harvested distal radius bone graft from the area of Lister's tubercle. Marked the scaphoid as one technical tip before taking it apart to curate out the cystic area, morcellized cancellous graft, guide wire, followed by a cannulated headrest screw. Given the size of this fragment, we used a somewhat smaller than typical screw, and you can see the screw buried. Next. And intraoperative fluoroscopic images demonstrating the screw and the bone graft donation site. Next. X-rays at 6 weeks, which are promising. Took her out of a cast and began range of motion at that point. Next. And her union was confirmed by CT scan at 10 weeks, and she returned to play at soccer at 3 months. Next. And so I think with my charge of staging, classification, and imaging, a couple of key take-home points that CT scan, particularly in the plane of the scaphoid, is really the current 2021 most useful study for evaluation of resorption, deformity, collapse, and union, as well as early degeneration. We've all been taught for decades about avascular necrosis. When drilling down into the topic of avascular necrosis, certainly I think all of us would agree that the literature supports it's poorly identified on x-rays. Unfortunately, the more you drill down into MR, which I think is in many ways utilized to assess for vascularity. The correlation between MR findings and the surgical findings of punctate bleeding and the histologic findings of avascular necrosis is really not what one would hope for in terms of accuracy. And so a word of caution on interpreting avascular necrosis in the presence of avascular necrosis. And thank you.
Thank you, Phil. So our next was by Jesse Jupiter, talking about the indications and advantage of non-vascularized bone grafts. Next, Jesse, turn it over to you.
Yeah. Okay, thank you. The index case is a young man who had an injury 6 months prior to presentation and presented with pain and loss of motion of the wrist and pain particularly over his radial column of the wrist. Next. And this is his presenting x-rays. The reason that it becomes relevant to talk about where the role of cancellous or autogenous corticocancellous is that it goes to the basis of why scaphoids don't heal. Scaphoids don't heal normally because either there's too much motion or there's instability of the fragments. The fact is that one of the advantages of a stable headless screw, or what type of screw fixation, is you've added stability in your treatment of the non-union. Because of that, we've not had to depend on introducing as much vascularity, but yet filling the space with just autogenous graft one way or another has proven to be successful in 90 to 95% of these cases. So here you see what looks like an avascular proximal component to the fracture. Next. Next slide, please. And the CT even confirms this. And ordinarily, one would be thinking about MRI, would be thinking about vascularized graft. Next. Next. At surgery, through a dorsal approach, you can appreciate the non-union, and the fact, if you look closely where the pointer is, there's sclerotic borders of these non-unions. Next. So by decorticating and creating a vascular environment and using cancellous bone as a filler, many of these will heal with just stable fixation. Next. And that's done through a proximal to distal screw fixation. Next. Next. That's measuring and then placing the screw. Next. And making sure that it's below the chondral surface. Next. And here's your image per se. So the point is that you may get changes in the radiographic appearance due to disuse and even temporary loss of circulation. But it's rare that these are truly avascular. More likely to see avascular where there's previous surgery or a more complex injury. Next. And here's the clinical motion per se, and ulnar and radial deviation. So I think there is a strong recognition that there's an important but well-defined role for a vascularized graft, although there's exciting grafts available, but most of the time with stable fixation and realignment of the non-union, the use of cancellous graft will be sufficient. Thank you.
Thank you, Jesse. Next, Kyle will talk about a snapshot on when you might consider a vascularized bone graft.
Thank you, Hill. Can I have the next slide? The index case I'm using tonight is a patient who had a prior attempt at surgical fixation for a scaphoid non-union, which obviously did not heal. And the features that we look at in terms of identifying the problems that need to be solved are, number one, the screw placement, which in this case is quite eccentric. Next. There were a couple of other, I'm sorry. Can we go back a little bit? looks like the animations are kind of taking over. So there were a few other features. There was eccentric screw placement. There's resorption. There is loss of bone stock throughout the middle third of the scaphoid, and then in the core of the scaphoid where the prior screw was. And then a question of how is the vascularity impacted by the prior treatment and the duration of the non-union. So this is a case that's going to be challenging to get to heal with more traditional techniques of bone grafting, in that there's an enormous amount of bone loss and there may be some vascular impairment with disc vascularity of the proximal and distal fragments. In this case, I elected to reconstruct this utilizing vascularized bone graft. Next slide. To look at the technique, this was approached from a volar exposure because the fracture and non-union site were in the middle third, and there's better access to the fracture as well as to the distal pole of the scaphoid for screw insertion in a retrograde fashion. So this is done through a standard V-shaped volar exposure over the scaphoid, and you can see that there's a proximal exposure that's planned over the distal radius for harvest of the bone graft. Next slide. The screw was removed and an opening wedge was created using joysticks in the proximal and distal fragments to recreate a normal scaphoid architecture. You have to use the joystick not only to elevate the distal fragment and correct the humpback, but it's also used to correct rotation. There's a lot of pronation that occurs in the distal fragment in most acute and certainly in chronic non-unions. And so you want to correct both the longitudinal alignment and the rotational alignment. And then I used cancellous graft from the floor of my vascularized harvest to pack the tract from the old screw with cancellous bone densely to remove any vacuolization in the fragments. Next. And then the graft is elevated. You can see that there's a cuff of muscle that's left attached to the graft to ensure that we have good blood supply and that we haven't over-skeletonized the vessels. And that's used to fill the trapezoidal volar defect and to create some stability in the longitudinal axis. And a new screw was placed parallel to the old screw. It was actually fortunate in this case that there was access to the central axis of the scaphoid for placement of a small diameter new screw without interfering with the old tract. Next slide. And this is the patient radiographically. She was casted for about 12 weeks. This was a pretty unstable fracture, and so casting was for the full 3 months. She looked well healed radiographically. You can see the donor site and the radial metaphysis is starting to fill in, and then CT scan at the 12-week mark shows good bony consolidation and central placement of the new screw. Next. I think we're back to you, Hill.
Hey, thank you, Phil. To wrap it up in 30 seconds or less, we talked about minimal defects, less than 33 millimeters, being handable by arthroscopy and grafting down through the track of your screw. Larger ones either open or arthroscopically with debridement of the site. And then, as we've just showed, larger cystic non-unions with collapse best handled by open technique, debridement, interposition graft. Next. Next, Marco. Most of the waist non-unions can be handled with non-vascularized bone graft, either cancellous or if you need some stability vascular, cortical cancellous. Vascular really for those non-unions with marked resorption, proximally, long-standing ones, and revision after previous attempts. Next. Failures mostly related to smoking.
You can take your time, Hill.
Smaller proximal defects. Thanks, Marco. Smaller proximal defects requiring a vascularized grafts can be handled with a dorsal source, such as this 1-2 intercompartmental supraretinacular vessel. Next. And larger ones with marked collapse or humpback deformity. Next. By a volar graft, as Kyle just shown, interposing it to correct the humpback. Next. Most of the failures will relate to smoking, a very important issue our faculty highlighted, failure to correct deformity, and attempting to apply reconstruction to a long-standing non-union. Next, as multiple studies have shown that non-unions more than 5 years in duration have very poor union rates and more likely require salvage procedures such as scaphoid excision and midcarpal, some form of midcarpal fusion. Thank you, Marco. In a nutshell, that was what my faculty contributed. And thank you all.
Thank you, Hill. What a thorough and outstanding session. And I can't thank you enough. That was brilliant. Thank you to the faculty as well. I am going to try to let Dr. Stern, any questions for Hill? I see some in the Q&A. Let me see. No, I think we're okay. Any questions for Hill as we transfer to Dr. Stern? Peter, do you want me to run slides or are you okay?
I think I'm okay.
Okay, but I'll give you the floor.
Okay.
Thanks, Marco.
Thank you, Hill. Thanks again.
So Marco, thank you very much. Chuck and Chai also, thank you. I had no idea we could stay on time. I'm shocked, and this will be a little shorter than the other presentations. My charge was to lead a panel on wrist arthritis, and the participants are listed here. Dr. Mudgall from Boston, and our wonderful Toronto colleagues, Paul Benhammer and Terry Axelrod, who you've already heard from. Oops. The first talk was by Chai on slack and snack wrists. One of the points that I think is critical, and he emphasized throughout his lecture, was that not all of these risks are symptomatic, and you treat the patient, not the x-ray. There basically are two categories for surgical treatment. One is motion sparing procedures, and the motion sparing procedures most common are very conservative things like a radial styloidectomy with or without a wrist denervation, and then the more traditional procedures, proximal carpectomy and four-corner fusion. Salvage procedure generally is a total wrist fusion. The next issue that comes out is how do you decide whether you're going to do a PRC or a four-corner arthrodesis? You want to know what the head of the capitate looks like. Is there loss of cartilage? What's the age of the patient? Their occupational demands. Smoking is, I think, a very important consideration, particularly if you're considering a four-corner fusion. And then finally, again, with four-corner fusion, if they're compliant with using a cast. His pearls for proximal carpectomy were that you should always plan for a capsulotomy for interposition, either proximally or distally based. So if you get in and the head of the capitate is somewhat eburnated, you can cover it with capsule. It's also important when doing a carpectomy that you save the radioscaphocapitate ligament because there's always the possibility of ulnar and volar translocation of the carpus. The capitate cartilage ideally should be helpful, although sometimes it's not. And as I mentioned, capsular interposition can be done as needed. As far as four-corner fusion is concerned, correction of the lunate extension and alignment, as Cohen and Cozen pointed out over 2 decades ago, is critical so that they line up with the capitate. I think the other thing that is very, very important is thorough carpentry in preparing the capitolunate joint such that all sclerotic and eburnated bone is used. Chai emphasized that K-wires work as well as more complicated forms of fixation. And he stated that fancy screws and plates don't always do the job. For his final summary, he felt that proximal carpectomy was better for patients that were 35 years or greater. If there was capitate arthritis, again, capsular interposition. This can be converted to a total wrist arthrodesis, and four-bone fusion is more common than proximal carpectomy. Surgical preference in this situation is either for four-corner fusion is just for stages 2 and 3. Next, Paul Benhammer talked about post-traumatic arthritis. And again, he stated that the highest priority in salvaging the destroyed wrist is to create a stable, pain-free joint. He talked about several procedures, all of which were incredibly well documented with the literature. Wrist denervation, it's a simple procedure. It preserves motion. Complication rate, of course, is low, but a fairly high DASH score of 29. Next, radioscapholunate arthrodesis, if the mid-carpal joint is intact, provides somewhat of a functional range of motion. It's categorically a technically demanding procedure, and there are significant complication rates, and he had in the literature, a DASH score of 33 points. I've really struggled personally with this operation. Arthroplasty would be done only in a low demand patient, significant complications, but comparable DASH score to the previous two procedures. Finally, total wrist arthrodesis. It's a salvage procedure, has a very high fusion rate, probably greater than 95%, with a DASH score of approximately 40, and that's associated with the loss of wrist motion. Finally, our cleanup hitter, Dr. Axelrod, talked about inflammatory arthritis. He made the point that we don't see nearly as much inflammatory arthritis, such as rheumatoid, because of the biologics and the BARD medication. Surgical treatment for inflammatory arthritis, less frequently used than it was in the past. Total wrist arthrodesis remains the gold standard for the management of rheumatoid or inflammatory arthritis of the wrist. He felt that there was a very limited role for, or a small role for limited carpal fusions. And he made the point, particularly with our European colleagues, that arthroplasty is on the horizon. My personal experience, again, interjecting, is that arthroplasty in rheumatoids is seductive, but it has not been very successful, particularly if you treat patients long-term. I have one case to show, and it's Chai's case, and perhaps, Chai, you could discuss this briefly in the remaining minutes, if there are any. What you see here, and what was your decision-making process?
Thanks very much, Peter. So this was a 69-year-old male, and he came to see me not for this, but because he had symptoms of tingling and numbness, and he really wanted, basically what he had was carpal tunnel syndrome. Next slide, please. And when I asked him about the swelling that he had over the dorsoradial aspect, which most of these patients have, which is a dead giveaway of the diagnosis, either in a SLAC or a SNAC, he said, oh yeah, I had heard that when I was something like a high school lineman or something of that effect. And basically what we have here is a 40-year follow-up of a SLAC wrist. Now, interestingly, I don't know if this is traumatic or not, because the X-ray on the other side also looked similar. But the bottom line is, like Peter emphasized, treat the patient, not the X-ray. He came to see me for tingling and numbness, not for this. So needless to say, he was not interested in any treatment. We left him alone. And after his carpal tunnel was released, he's gone on just fine. Doesn't really bother him anymore.
Great. Thanks, Chai. That's it for me, Marco.
Thanks, Peter. Wonderful stuff. One question I did have, Peter, I know, or I don't know, but I assume you're a fan of the proximal carpectomy from your publications. What's the current 2021 recommendation on your age? I mean, would you consider a proximal carpectomy in a 28-year-old, a 22-year-old?
I think it would depend on their level of activity. Lindley Wall and I looked up a series of PRCs that I'd done many years ago with an average follow-up of 25 years, minimum follow-up of 20 years. The bottom line is that about a quarter of them at some point failed and went on to a total wrist fusion. So my thought is, based on the greater demands in younger people, that if you're going to do a motion preserving procedure, that a four-corner arthrodesis seems more reasonable to me than a carpectomy. Whether it's Chai's 35, whether it's 40, 45, I think level of activity has a lot to do with it. My guess as I ride into the sunset would be that the biomechanically, to me, a four-corner fusion makes more sense. But as is pointed out by many, many people, including the group from Salt Lake City, there's a higher failure rate in the like type 1 and 2 slack wrists with a four-corner fusion. So you got to weigh early complications of four-corner fusion versus fairly high success rate with carpectomy, but ultimately, because you're with a carpectomy creating an articulation between a small ball and a large socket and a lot of translational motion, carpectomies probably, at least radiographically, are doomed to fail in the long term. Too long-winded of an answer, I apologize.
No, not at all. Thank you, Peter. As always, your wisdom is really helpful, and thank you for sharing. Could I ask you to stop sharing your screen, though?
You bet.
Thanks again, Peter. Wonderful stuff, and thanks to the faculty. Unfortunately, Dr. Osterman is not with us today, so we may have a couple comments from maybe Dr. Hunt and Dr. Wysocki, who were on that group. If you want to, we could maybe share that now, or I could go, and we're coming down the home stretch. We really only have one talk left, so why don't I just do my talk real quick on a summary on our session on total wrist, and then we'll see if there's time allowing, Tom and Rob can chime in. So I'm going to share my screen real quick here. And so our session was on total wrist arthroplasty, which is, as Dr. Stern so kindly pointed out, is not usually a favorite of many surgeons. So we're going to take our lumps and go with it. We had a wonderful group of faculty, tremendous. Dr. Gupta and Dr. Adams are both folks who've designed implants and continue to do so, have a tremendous experience. Dr. Osman has published one of the largest series on outcomes of arthroplasty and hemiarthroplasty. So I couldn't imagine a better group of faculty to work with. And then I followed up with a discussion on total wrist failures, which sadly we see not uncommonly. Dr. Gupta spoke briefly about indications. He described, what are the indications: bilateral disease, rheumatoid patients, pan-carpal arthritis, patients really desiring a motion-preserving option. Folks with fusions of the contralateral wrist fit into that category. And we highlighted the fact that the newer generation designs have demonstrated encouraging results and continue to do so. Recent meta-analysis looked at the newer generation designs, and while they did confess that the risk, it's a higher risk, higher reward procedure, it does provide better outcomes than previous generations. Dr. Adams shared his expertise in technical pearls, recognizing that TWA is a generally very technically demanding procedure. Help yourself, provide yourself a generous exposure in these patients. Be precise with your bone cuts, protect the soft tissues, preserve that dorsal capsule, which is going to be very important in protecting the tendons and also facilitating a nice closure for the implant. We discussed some pearls, such as the liberal use of fluoroscopy, decorticating the intercarpal spaces to help facilitate an intercarpal fusion, which would hopefully help the survivorship of the distal component. We spoke briefly about the DRUJ and protecting it and preserving it when possible, and what to do in terms of addressing it when necessary. Again, Dr. Osterman spoke about hemiarthroplasty as an attractive potential alternative to total risks. Primarily, the advantage is largely in that you limit bone resection, you have less prosthetic stress, it's easier to convert to an arthrodesis, and you can salvage potentially a prior PRC a little bit easier with these implants. But there were cautions and lessons learned from his experience, which he kindly shared. Avoid bone-on polyarticulations. This has been shown to be a poor outcome. Typically, even bone and metal articulations are concerning and don't seem to work in other areas of the body. So those should be approached with caution. And we concluded that more data and longer term follow-up would better validate this option. And then I spoke about failed arthroplasty. A recent meta-analysis suggested that revision arthroplasty, as well as even fusion following previous arthroplasty, is fraught with reoperations and less satisfactory outcomes. Revision arthroplasty, there's only a couple papers really looking at revision total risks. Oh, there's Dr. Osterman. Hey, Lee, how are you? And we thought better fusion rates with newer plates and locking technology was somewhat reassuring in discussing with patients, what do we do when this fails or if this fails? And I'm just going to highlight a quick case that's a little bit unique, but shares with us some of the newer thought processes. This is a patient who had bilateral slack wrists. She underwent a four-corner fusion on her right side and did okay for a short while, but you know, we've seen this before where 1 year post-op, she's having pain. We had some concerns about potential non-union. The pain was fairly persistent. We discussed further motion preserving procedures as she was reluctant to have a full wrist fusion. And we opted to consider a wrist replacement in this patient. This is 6 weeks after the wrist replacement. On the left side, she did have pain as well. And the plan at that point was, given the poor experience with the four corner, to move forward with a total wrist arthroplasty. The right side goes south and gets loose and it's painful. And at this point, I opted to move forward with an arthrodesis, which went on to do well. Her left side developed progressive osteolysis over the 4, 5, and 6 year period, as you can see. And this is one of the problems with these wrist replacements, is osteolysis. More often, it's a distal problem, not so much a proximal problem. But in this case, it turned out to be proximal. And in this case, it's a little bit of a mystery as to what exactly is causing the osteolysis. Is stress shielding or debris from polywear or from micromotion of the implant? Then in this case, noting that the component was well fixed, we opted to move forward with bone grafting, selective bone grafting through cortical windows in an effort to help support the implant. The implant distally was well fixed. The poly was exchanged. Interestingly, the poly did not have a lot of wear in it. And Michel Beckstein has done a lot looking at this in terms of investigation, but I really think the summary of this is that we don't have any obvious answers. And in summary, this is the patient 6 months after bone grafting with a more reassuring x-ray and continues to have a pain-free wrist. So I'm going to stop my session as I see Dr. Osterman is here. And Lee, I'm happy to give you the floor here for the last session. Thanks so much, bud. I think we need to unmute. Okay, great.
Should I share my screen, or you're going to pull up my slides from?
If you're able to share, I couldn't, feel free to share, Lee. Is that okay?
Yeah.
Okay, thank you.
You're welcome, Marcus. Sorry, I got tied up in the OR for things. I assume
No,
the
no
screen,
worries, bud.
the screen is up. So our session was on wrist arthroscopy, and the take-home points from it were that besides the TFC, which is becoming a fairly standard approach arthroscopically to address it, there are other things that we can learn or fathom. And what I thought I'd do is to kind of hit one topic that we didn't talk on, but one I think which is changing my paradigm for carpal injuries. And so the case I'm going to present is a 25-year-old professional hockey player, obviously plays for the Flyers, who I think just got eliminated, but this is not this year. He got his wrist slammed into boards, immediate pain, goes to the locker room as they can, and they get this x-ray in the locker room, and it doesn't take much figuring out from the hand surgeons on this call to realize this is a classic perilunate dislocation without fracture. And so you say, well, what's the next move here? He was splinted, and it came to us, and they and what we elected to do was to reduce it, and that was done the night of surgery. And then 2 days later, he had an arthroscopic evaluation, and so we see the 3-4 portal, and surprisingly, you do see the tears of the ligaments, the scapholunate ligament tear there, lunate there as we swing over. PFC is okay, and the is the probe looking at the LT, at the TFC, and the LT is torn as the probe is showing. As we look in the mid-carpal joint, again, looking from the radial mid-carpal, the articular surfaces are good. Sometimes you'll see some condyle injuries, but it's easily reducible, as you can see here, with pressure and lining it from the mid-carpal joint. So suffice it to say, we reduced it and then proceeded to do capsular shrinkage of not the interosseous ligaments as much as the volar and dorsal capsule. So the dorsal radial ligament, the dorsal capsule over the scaphoid, and then the mid-carpal joint, the volar and dorsal ligaments. He was treated with pinning, as you can see here. The pins were left in place, buried for 6 weeks. They were then removed. He was started on a therapy program, and at 3 months post-injury, a very reasonable range of motion, excellent extension, some limitation of flexion, and a reasonable grip strength, and was able to return for the playoffs. And so one of the questions that I think we have to look at is, for me anyway, the perilunate injury has always been a nudge. I would line them up, put screws in, open them up, repair the ligaments, and I'd end up with a wrist which radiographically I could shout about, but which functionally was pretty doggone stiff, and often that stiffness remained. And I said, well, you got a stiff wrist, but at least it's located. And so I think we can do better than that. Interestingly enough, Buddy Savoy first wrote about arthroscopically assisted reduction of perilunate dislocations way back in 1995. It sort of lay fallow for a while until Park presented 3 cases. Finally, Guillaume Hertzberg, who's a French surgeon, took a kind of mixed bag of 135 perilunates and transcaphoid perilunates that he saw. 27 were approached essentially with a very limited approach arthroscopically. When they were opened, it was to put a screw in the scaphoid, essentially, or sometimes a small little mini suture anchor. And he presented the data such in a kind of nice way to think about things. The red line, which looks like the outer part of a spider web, is kind of the normal. And so you get points to on that diagram, if you will, for pain with certain rotation, pain with wrist flexion, motion in terms of that. And so his outcomes in the group were summarized by that yellow line that you see. So not perfect, but overall reasonable wrist motion, good VAS scores in terms of pain, reasonable grip strength, all the scaphoid heal. And at follow-up at roughly 3 years, they had normal carpal alignment without evidence of arthritis and no revision surgery. So I think, again, this is where we ought to be thinking, and this is some of his X-ray parameters showing where they were right after the surgery, where they were hours down or years down the road. Kim, in a recent report in 2015, again, looked at perilunate and transcaphoid, the same sort of arthroscopic approach, using essentially the fixation that you see here without many opens. And again, got results which, looking at kind of at this thing, range of motion in the 80% range, good wrist measures, good dash scores. He did have 3 failures, one because of CRPS and 2 because of scaphoid non-union, and 1 fell apart at a 3-year follow-up. Our study, in looking at patients over 2 years, these are all pure perilunate, so no transcaphoid perilunate. None of these patients were opened up or had any type of anchors inserted arthroscopically. They were all treated with K-wire fixation. At a greater than 2-year follow-up, we had the kind of motion you see, reasonable grip, no re-ops, no X-ray arthritis, and maintenance of essentially normal parameters in 2/3. And so I bring it up in the sense that I think there are some advantages. It protects the scaphoid vascular supply. You preserve the secondary stabilizers. It gives you a good sense of whether there are any intra-articular components to things such as a carpal avulsion, and you can do a relatively straightforward fixation. And for me, like treating a ganglion, which I use arthroscopy for more often than not, it sort of revolutionized a problem where I was always hanging crepe, always saying you'll be lucky if we get 40-40 kind of motion. Now I take a much more sanguine view and believe that we can get a kind of 80% wrist in these patients and get them back sooner with less therapy demands and with reasonable function. And so I leave that as a kind of where should we be moving with arthroscopy and how should we approach some of these carpal injuries with it. And I'll stop at that point.
Thank you, Lee. It's a very provocative, and I've seen Guillaume present on his experience as well. I don't want to, I was going to ask a question. Are there any patients that you say, I'm not going to try this on it, or are you taking all comers for these?
No, if they have an open carpal tunnel, we didn't include them in the series. So if you had an open procedure, if we couldn't get a reduction that we thought was anatomic, and there were 2 patients in the group of the patients that we had. I think of those we planned to do it, there were 5 exclusions, 2 because of carpal tunnel surgery, and 3 because in 1 we found a scaphoid fracture and a capitate fracture, which were not seen on the obvious X-ray, but clearly at arthroscopy saw it. And so that necessitated opening to put screws in. And there was 1 patient that we just couldn't get an anatomic reduction with the joystick pens, et cetera. So, I mean, there are going to be cases which you can't do it. And I think you have to consider that. But many of these, as you know, are young. The average age and the people we did it in was 24. So they usually have fairly good healing potential. Most of them, they're usually things. And all of these ones we we treated were treated within a week. So we didn't have any of the late five-week-old who came in from the emergency room with a missed perilunate. So suffice that to say that other than that proviso, I would say it takes most comers with a pure perilunate.
Thank you, Lee.
I have a
Rob-
question for Lee, with your perspective now, do you think it's overkill for us to be repairing the ligaments when we do an open perilunate?
I'm not sure overkill is the right word, Chuck, but certainly I think you're asking for more stiffness. And, you know, I repaired them like everybody else and ran pins or screws across them for a while. And if it falls apart on you, you're gonna say, should I have done things differently? But yeah, I do think it's overkill. Yeah, I think with the magnitude of injury, I think there's a lot of potential for healing, and I think some of the secondary structures are still stable. And I think that because of that, you can, in many of these cases, do what I just showed.
Yeah, my mentor, Len Ruby, was a big fan of anatomic reduction without fixation, without ligament repair. Anatomic reduction, stable fixation without ligament repair.
Yeah, I think
Thanks.
we've kind of gone over the other way with all of our internal braces and our MyTech anchors and et cetera. And they just always ended up stiff for me. And while, you know, I could crow about the x-ray sometimes, the patient, you know, you were kind of cheerleading, say, you'll be okay, a little stiff wrist won't be the end of the thing, you know. And they're telling me they can't do push-ups or the missionary position and this and that. I got tired of hearing those complaints.
Thanks again, Lee. As always, wonderful. I think we're done. We're about 7 minutes over. So again, I can't thank our faculty enough. Thank you to AO North America and the staff, Doreen, Joanne, Jane, and everyone at AO North America. Thanks, Mackenzie, for helping us with all the tremendous burden of the IT technical challenges and keeping us on Zoom. Chuck, thank you. I'm going to let you have the last word, buddy. Okay.
Oh, Marco, you always do. You are so gracious, and great job tonight, and great job to all the faculty who just said yes. As we mentioned earlier, you know, when we came knocking, everyone just said we're up for it. And one of the benefits of this crazy time, this COVID time, is this virtual learning. And this experience, I think the audience that we've had has been fantastic and much higher than it would have been had we had a on-site risk course. And fantastic job to everybody, and thank you.
Have a good evening, everyone. God bless.
But Mario, before you leave, Chuck, quick question from the audience, and maybe Chai can answer this as to how to get your CME credits for this. I think this was something that was going to be done after all of the sessions. So if you could comment that for the participants, I think that'd be appreciated.
Okay. Well, yeah, so there's a survey link that everyone's going to get. And when you fill out that survey link, you'll have the option of getting the 13.5 CME credits for the sessions. Okay.
And Marco, if they have any difficulty with that, they can always email either you, Chuck, or me personally.
Please do.
We can take care of it on the back end also.
Perfect. Thanks, Chai. Good night, everyone. Have a great weekend. Take care.
Okay. Good
Bye
night,
now.
all.
Thanks again.
Stay safe. Bye-bye.
You as well.